So we've got just under half an hour together now to just discuss some of the things that we've been hearing about. I've got a number of questions, and then I noticed that we've got a few questions already coming in the Q&A on the Zoom. So if you've got questions, please do put them in the Q&A, and we'll try to either speak to them during the course of this meeting or in written responses afterwards. Great. So first question goes to Monicah. Given the persistent backlog in many countries that we've just been hearing about, which health system innovations do you think are proving most effective at scaling up cataract surgical services?
Yeah, thank you, Martin, and greetings, everyone. I think when it comes to scaling up cataract surgical services, we need to look at this from the demand side and also from the supply side. And from the demand side, I'd like to start by talking about what we can do at the community level. We need to address the barriers that are often faced at the community level when it comes to accessing cataract surgical services. And some of the key barriers include financial barriers or cost barriers. So we need to find strategies to address the cost issue so that people are able to access services and are not turned away because they cannot afford the services. The other thing is physical, ensuring that there is accessibility physically. And this is taking into consideration the different geographical vastness in different countries and even in different counties, even within a country like Kenya, that you'll find that some counties are quite vast and the geographical access becomes quite difficult. So how do we then come up with ways to ensure that we are taking the services closer to the people and not necessarily waiting for them to come to the base facilities? So perhaps strategies around mobile eye clinics, outreaches, just taking the services closer to the people. And then the other barriers that you see at the community, again, is a lot of misinformation and misconceptions. So we really need to strengthen health promotion so that we address some of these myths and misconceptions, and so that people can come forward to seek these services. And some of the strategies we can use is sharing success stories, or even using those who've had successful cataract surgeries to be our champions and to promote positive attitude towards uptake of cataract surgical services at the community level. We also need to target the opinion leaders at the community, because they are the ones who enable us to enter the communities and to talk to this to our community members so that they can come forward for cataract surgical services. So bottom line, we need to work with the communities, and when communities trust our services, then they're able to come forward and demand these services, and that automatically increases or naturally increases the demand. The other area that we need to look at is when at the health system side, and we need to ensure there's a continuum of care, so that you're not just offering services at the secondary and the tertiary level facilities, but you're also having primary eye care integrated into primary health care. Because most of the time, the first contact patients come across usually are primary healthcare workers or the frontline healthcare workers. And it's really important that they are capacity built with basic skills or basic knowledge on eye health, because they're the ones who help us in identifying these patients and ensuring that they are referred appropriately. And the primary healthcare, again, when you integrate primary eye care, it becomes like a triage and a referral mechanism for eye care services. Then at the secondary level, we also need to ensure that our patients are getting a positive experience. When they come, services are efficient and they have a good experience. We have reduced waiting time, proper patient flow, and all that. Then when they go back to the community, they help us in advocating. They become our advocates, basically, and they ensure that the demand also goes up. So when the clients are satisfied based on the services that we are offering, and they get positive outcomes, and they directly drive the demand at the community level. Then at the policy level.
Yeah, I was wanting to ask you a bit about policy. What policy levers have you found to be really useful in the Kenyan context?
Yeah, so policy is really key in driving or in scaling up cataract surgical services. And some of the policy issues or policy levers that you can look at in Kenya, for example, is use of that's on health financing. And we have what we call the social health insurance that has a package for eye health and for cataract surgeries. So ensuring that as many people as possible are enrolled into these insurance services so that they can be able to access services at an affordable cost. Because when we leave them to depend on out-of-pocket expenditures, then they really struggle to access these services. So insurance is really important. Health insurance at the national level is really important, but also using mechanisms like ensuring that eye health is integrated into primary health care, into community health is really, really key. Because, as I said, the primary healthcare level is where most of our patients enter the health system, and that level is capacity built. Then they're able to identify and refer patients appropriately. Then also ensuring that we have an enabling environment by having policies that ensure there's a strengthened supply chain system, there's a strengthened human resource system that ensures that we have equitable distribution, and just ensuring that you're addressing the health system building blocks so that we address eye health comprehensively. And some of these have to be done at policy level. Yeah, thank you.
Great, Monicah. Thank you so much for sharing those insights. Can I turn to Amanda now, please? And it'd be lovely to hear from you what you're finding through your work, both personally and Fred Hollows Foundation, are the primary causes of differences in quality in cataract surgery between countries.
Thanks, Matthew. I hope you can hear me clearly.
All good.
Thank you. Thanks, everyone. Well, when we look across countries where the Fred Hollows Foundations, we have programming supporting cataract services, I think the difference in cataract quality are really about surgical technique alone. And in most settings, I think the real difference really sits at system level. First of all, for example, training pathway and ongoing mentorship varies enormously. In some countries, surgeons have structured supervision, peer review, continuous learnings built into their practice. In others, once formal training ends, there are very limited mechanisms to support continuous learning and also quality improvement. And secondly, I'd say data availability and utilization also varies a lot. Many countries do not routinely collect or review visual outcomes or patient experience status. Without data, outcome data is very difficult to understand where quality is leaking or how to focus and improve the quality. And we see countries where we do have systems like cataract surgical outcome monitoring programs. The quality improvement seems faster and more sustainable. And I think the third area probably is health system and facility reliability, which really matters just as much as individual skills. And this, for example, may include consistent access to functioning equipment, maintenance systems, standard operating procedures, a series of workflows. In some settings, availability of supply chain and equipment downtime can directly affect surgical outcome, consistency, and also patient safety. And finally, I would say governance and accountability really play a big role. Countries that embedded quality expectation into national policies, accreditation systems, and reporting frameworks tend to see much more consistency performance across facilities. Where quality is treated as optional rather than essential, it really varies. From our experience at the Fred Hollows Foundation, for example, including some of the recent continuous quality improvement work in China and across Asia and African regions, countries that perform best are those that treat cataract quality as a health system responsibility, not just as individual clinician issues. So in short, I would say quality difference really reflect a policy choice and a system designs, not just clinical capacity.
Thanks, Amanda. And what actions have you seen or found have really helped to promote increasing quality, both of delivery and outcomes?
Thank you, Matthew. What we've learned is that quality improves when actions are structured, data-driven, and also embedded into routine health systems. One of the most effective actions has been adopting clear shared quality standards, such as what we are discussing today, the new WHO cataract quality guidance. These standards helps align expectation across government ministries, hospitals, facilities, clinicians, and also patients. And importantly, this can shift the conversation from a single focus on volumes, the number of services provided, to effective coverage. And secondly, I think routine outcome monitoring is transformative across our global continuous quality improvement work, including, for example, pilots in Bangladesh, Kenya, Ethiopia, and more recently scaled programs. Introducing simple outcome monitoring system has enabled our teams and partners to identify problems earlier and test the solutions quickly. For example, in China, our CQI work has focused on embedding outcome monitoring and continuous quality improvement into existing national cataract capacity building systems. So rather treating this as a parallel process, we work with partner and ministry to including tools such as PDSA cycles and outcome review into hospital practice and also training programs. And this approach has helped normalize quality improvement as part of routine care, not standalone project. And thirdly, for example, in our Nepal program, mentor-mentee peer learning also matters enormously, where between hospital, surgical team, or province, these mentor-mentee programs allow a practical problem solution-based peer support mechanism. And we've seen this work particularly well when combined with regular data review and a facilitated learning process. And finally, quality improves when we also put the lens of people-centered care, better pre-operative counseling, realistic expectation setting, and also improve the follow-up, not only improve outcome, but also increase patient trust and also compliance. And across all these actions, the key lessons learned is consistency. When quality standard data, training, governance, leadership reinforce each other, as encouraged in the WHO guideline, improvement becomes sustainable. So overall, addressing cataract blindness and vision impairment remain as one of the highest priority for the Fred Hutch Foundation. And we continue to work with WHO and partners across the globe to promote these tools and help strengthen health system.
Amanda, thank you so much. Really helpful insights into the value and importance of data driving quality improvement and then approaches to systematically working on that. I'm going to turn to Jacqui now, and I'd like to ask you about how the data we've been talking about today and similar data can be used to better understand inequality in the provision of cataract services, please.
Yep, thanks, Matthew, and congratulations to everyone who's presented today. I guess I wanted to highlight a point that we made in the paper, which is that the lack of a significant gender disparity that we found, there's only a 2% difference between men and women ECSE in the paper. The fact that we found that at a global level doesn't mean that we've solved gender inequity, and just highlighting that it's encouraging that we're moving in the right direction, but that the estimates are aggregated and modelled. So underneath that sort of global estimate, there's still be many settings where gender disparities persist. So I guess I just wanted to encourage everyone to continue to use local data to sort of drive gender responsive programs. And then the second, sort of along similar lines, I'm sort of wanting to encourage us to think about expanding the social axes that we use to monitor inequality. So, and this will be really different in different settings. And just thinking about perhaps some of the work that's in this new WHO document, but certainly in the ICARE indicator menu, we have some measures in there that we can use to monitor whether or not we're moving in the right direction. Such as access and quality in terms of the key components of ECSE. And I thought sort of preoperative visual acuity is a really nice example of a measure that we can use as a proxy measure for access. And so here in Aotearoa, New Zealand, where I live, thinking about our ethnicity is a crucial social axis that we have to use to monitor cataract services, because our Indigenous peoples, Māori, we know that they access services with much worse preoperative visual acuity than other New Zealanders. And so it's a key sort of example here that we can be using these service-based indicators to know whether or not we're moving in the right direction towards effective cataract surgical coverage. So for us, knowing that we need more accessible services for Māori, even though we don't have survey data here, but we can use that to know if we improve access for Māori, we'll be moving towards improving ECSC for the country. So,
Jacqui, just a short follow-on question. I know in the past you've done quite a lot of work on looking at multiple, as you mentioned, multiple axes of differences between people and how those characteristics can interact with each other, leading to some groups being really disproportionately left behind. Can you just speak to that a little bit and the value
sure.
of that data?
Absolutely. And yeah, so it's sort of this cumulative disadvantage, or the cumulative barriers to services, the more axes along which different population groups may experience barriers. And so a key example would be for gender. So not all women are the same. So there are women with plenty of resources who are able to access services. And so it's thinking about within women and thinking about the populations that we're serving, what would be the axes that might combine. And so obviously rurality is a big one. So if it's rural women or rural women without good social support, so maybe women who are not married or women along socioeconomic status and things. So it's sort of not just thinking about men and women as a group and women, the gender disparity is not now gone away, because underneath that will be these other things that we need to think about.
Great, thank you. Thank you very much. Stuart, can I turn to you now? The question really here is, what are the caveats? What caveats are there in using CSR, cataract surgical rate, and ECSE, both for progress and reporting?
Yep. Yeah, thank you, Matthew. I think it's a very good question, and I think it's been highlighted a bit throughout some of the responses. But so effective cataract surgery coverage in particular, if we stick with that for a moment, of course, is an important indicator to periodically track the impact of the work that's been done in the country at a country level in terms of access and also quality. It sort of gives a one point in time snapshot of the quality and access to service. However, the key point is, and it has been mentioned by Jacqui, a much more comprehensive set of indicators are needed to inform evidence-based planning and decision-making around cataract surgery in countries. And WHO has dedicated some time and resources in this space. In 2023, we launched a standard set of routine health information system indicators in a DHIS2 module. Within that, it includes additional indicators such as waiting time, preoperative visual acuity, and surgical outcome. But we're building on that at the moment, and over the course of 2025 and 2026, we're developing a case-based reporting for eye care indicators, but it's very heavy in cataract surgery-related indicators. It includes even additional indicators such as dropout rates, complication rates, those types of things as well. So we're looking forward. We are going to prioritise this moving forward, and we're in the process of identifying a few countries now to pilot this work so that we can move it forward and make it more widely available.
Great, thank you. And do we need additional indicators to better capture coverage, do you think, quality and equity? And do you think we've got the toolkit we need?
Yeah, I think we're heading towards the appropriate toolkit, but I do really need to underline the fact that the work needed around supporting countries to strengthen their health information systems is critical. It's not easy. It needs some alignment in terms of HIMS processes in countries, convening of experts in countries. So that's really the key point I'd make. So really, we need all stakeholders in countries to come around this and really come together to support strengthening of eye care data, including cataract surgery indicators within routine health information systems in countries. I think we're getting there with the level of indicators now.
Yeah, great, thank you. Andrew, can I turn to you? And just ask you about incentives. What sort of incentives do you think need to change for the problem of cataract to be addressed sustainably?
Thanks, Matthew. I I'll answer this in two parts. First, kind of building on Stuart's point and Jacqui's around different types of indicator. So obviously ECSC is a visual acuity based indicator, and I think anyone who's in clinical practice will know there are patients who have a poor preoperative vision and have a slight improvement, who it's transformative in terms of their life and function and quality of life. Equally, there are some who move across a threshold of visual acuity for whom it doesn't change their visual function. So I think it's partly acknowledging that a quality outcome has multiple dimensions, and I know that's covered in the new WHO guidance as well. So that starts to feed into what are the incentives. Our quality of service is a key thing. So we can think that how else do we measure that quality of service? There is a challenge, and a very real one, that I think we all need to be alive to, that if you are a eye care provider in a low income setting, you are often put in a position of having to choose between either doing well or doing good. So if you want to make a reasonable living and income from your work, you tend to need to work in the cities where people who can pay out of pocket with a decent margin exist. And so as an incentive to do surgery in the rural areas where the greatest need is, actually at the moment that there isn't a strong one. It's largely a moral one. And we're very fortunate to be in a sector where there's many people who are committed to that, but that's not enough. So I think the challenge ahead of us, and Monicah touched on it in terms of financial security and systems around this, is how do we ensure that if demand is generated from people in the lowest income settings, that also balances with reliable, regular income for the providers, so that they can move from doing outreach type activity as a externally funded program to a self-funded program, because there is not just a if you like, mission incentive to do so, there's a financial one to do so. At that point, the system will start to pay for itself, and we'll move from a current problem of lack of patient financial access and lack of supplier financial security to grow, to how do we optimize the system for improvement and growth? Because the risk is we can have all of the processes and toolkits around improving services and monitoring, but if there is not an incentive at the level of the provider to stay in that job, to grow, to do more, we don't have the underlying support system for that to happen. So I think we really need a way to address that.
Thank you, Andrew. Really insightful observations there. Lots to think about. Jacqui, can I come back to you, please, and a bit of a question about data and what you think the biggest challenges, but also the opportunities for collecting high quality cataract service data, potentially.
Yeah, so I think a key opportunity is the potential for the increased value that countries might place on cataract service data now with the WHO target and the reporting needs. And we're sort of working on a really exciting project at the moment in China and Nepal in partnership with the foundation and the respective governments and NGS. And I think looking at, as we're sort of working towards, our question is there a way for us to work towards being able to update ECSC estimates using routinely collected data? And it's been really exciting to work with partners in the country and seeing the increased interest in cataract service data, which is collected at facilities, and the quality absolutely could be improved. But there's a lot of service-based data there that we can be knowing if we're moving towards driving up ECSC. So I think that I think Amanda and Stuart have already said it so well. It is an opportunity to, and sort of working together to improve health information systems, I think is a really critical way, but also working with governments to so that they can see the value of this in terms of their reporting obligations. I think it's a challenge and an opportunity.
Great, thank you, Jacqui. Just in the last few minutes, can I circle back to Stuart and then potentially Andrew to think about people, human resources, and what you think are some of the key challenges and opportunities, again, in relation to the eye health workforce?
Yeah, so I'll be extremely quick, Matthew. So no doubt, of course, a lack and maldistribution of workforce at all levels, from screening to diagnosis to actually surgeons as well, is one of the key bottlenecks to increasing access. So I think Monicah said it very well. I think the strengthening of the health workforce needs to happen at all levels, including the primary health care levels. I wanted to also flag that WHO has just released in December last year some new primary eye care training resources to support this exact thing. Of course, then, we need standardized training programs for surgeons as well to increase number and better the distribution. But it's also about addressing the inefficiencies some inefficiencies. Of course, at the moment, we see in many countries, ophthalmologists and surgeons are really tied up with non-surgical tasks quite often. So freeing their time up to do what they do best, to do surgery, is also something that can only happen if we strengthen the lower levels of the health system.
Great, thank you. Anything to add, Andrew?
Yeah, I mean, I think Stuart covered all the key points, and just on the maldistribution and inefficiencies, partly when we look at the data, it's often 20% of the surgeons are doing 80% of the surgeries. So when we talk about needing more surgeons, actually, I think the first problem to tackle is more surgeries. And if you have more surgeries, it's that incentive system. People want to work alongside other surgeons and surgical teams and have mentorship and community. Then it becomes an attractive profession. So it goes down to, you get the demand right through strong primary eye care, you get the quality right. All of these things need to come together in concert for this to work.
I think we are almost at the hour. It is easy for me to say thank you very much for those of you who've joined online. We really appreciate the time you've given us today. Thank you very much to the panel for the presentations and for the really lively and interesting conversation. I'm mindful that there are a lot of open questions in the Q&A, which we'll seek to respond to in writing. Unfortunately, there isn't time to take these now, but there are some really excellent points, suggestions, and questions there. So thank you very much. We will be doing it again later in the day, if you are up later and want to listen to it again. But it will be available online eventually as a recording. Thank you very much.